So lastly, I'll introduce Oliver Wiseman and Andrew Winterbottom from Cambridge, and they're going to talk about Ultra Mini PCNL. Perhaps with the benefit of Andrew being a radiologist, he can also talk about some of the aspects of puncture that we haven't really covered so far. And also one of the questions has been, what's the size difference between standard, mini, ultra mini, micro? So if you're able to fit that in.
Good morning, everyone. Thank you, Kay. Thanks very much to Andy for joining us as well. So please make use of his presence and ask any access-related questions. We'll start this case, and then there is a kind of pause in the middle of it where we can probably talk about the different size ranges. This is an 83-year-old man who had visible hematuria, fit and well. He wanted a one-off treatment as a carer for his wife. This is a hard stone in his left kidney, about 17 millimeters, and we discussed the treatment options: lithotripsy, flexible ureteroscopy, and PCNL. And if you actually look at this lie, you can imagine that if you fragment this stone with lithotripsy, some of those fragments may well drop into the lower pole, and the same issues you may well have with flexible ureteroscopy. We start off by putting a retrograde catheter up from below. We had a few problems doing that, actually. It was the hardest part of the case. We use a little J wire to help us get up. We've got the retrograde catheter up into the kidney, as you can see. Turn the patient prone. I'll hand over to Andy to take you through the puncture.
And you can see that there were some dilated lower pole calyx, as on the CT, so I've got a nice easy target to puncture there. You can see the echogenic stone. You'll see the needle coming through the cortex very shortly. Tip of the needle was in the calyx, and then we just carry on, manipulate a wire to the ureter alongside the ureteric catheter. That's a standard micropuncture kit, 018 wire to start. You'll see the wire flick shortly towards the ureteric catheter. Sometimes that requires a hydrophilic wire and angled catheter, but that time it just went straight down the ureter.
Thanks. I'll take you through the kit now, because many of you won't have seen this. This is a 1 millimeter scope which goes into the inner sheath, and the inner sheath has got the 1 millimeter scope which goes in the middle here, and then two side ports, one of which is for irrigation and one of which your laser fiber goes down, and then that will then fit through your outer sheath, which comes in two sizes, and there's an obturator which you basically use to get the access. So this is Andy again now getting access. You've dilated.
Pre-dilate you with an 8 and a 12 French dilator, and then this is the 13 French sheath going in. It's quite blunt on the front end, so you've got to be slightly careful. It's not as tapered as some dilators, so a little bit awkward just when you're pushing in to make sure it goes in straight.
So dilated into the kidney, the inner obturator comes out, and that leaves us with a guide wire there and the outer sheath. Now it's kind of a scary moment, because normally I like to have a wire on the outside, as we talked about for the other perks, a wire on the inside as well. But you'll see with this kit, in fact, this is the kit here, the outer obturator. There's a flushing port on the side, and that connects to a little tube which runs down the middle of the kit and allows you to flush fragments out. And if you have a wire which is going down, it affects your manipulation around the collecting system, and it also means that you can't flush out the fragments, which is one of the big benefits of doing this over a flexible ureteroscopy. So we have a wire down there at the moment, but very shortly we're going to remove the wire, and that then leaves us with just the outer sheath in the collecting system. So obviously it's very important that that's where it remains, or else we need to get access again. Now, one of the concerns which I had, this was actually our first case which we have done of Ultra Mini PCNL. We had Janak Desai, who was the founder of the procedure, who came over from India, and we had a workshop where we did a couple of cases. I didn't really know with such a small sheath what the bleeding would be like, and I was kind of concerned that you get into the collecting system and your vision would be significantly affected, and you wouldn't really be able to see very well at all. But in fact, my fears weren't proved to be true at all, because you can see you've got a very nice view of that stone there. There's very little bleeding, and you can see the stone is just, we've got access in through the lower pole here, and you can see the stone is just wedged in that infundibulum between the pelvis and the lower pole. So what I was alluding to before is that if you come from above or you've done a lithotripsy on this patient, you can imagine that all of these fragments will have fallen back towards where we were, and that's a pretty dependent calyx. And I would suggest that they would have actually just sat there and been very, very hard to clear or very hard to access and pick out with a flexible ureteroscope. And one of the ideas of the operation is that you don't really want to create dust. You want to create fragments which you're going to be able to wash out. And therefore your laser settings are very important, and those are the laser settings which we had for this case. So 8 Hertz, 1.5 joules, it's about a 17 by 17 millimeter stone. With these laser settings, you're aiming to produce fragments which are about 2 or 3 millimeters, which then you can flush out. It was quite hard to access the stone when it was wedged in the infundibulum, and we've just nudged it now into the renal pelvis. So you can see we've got a relatively good view of it here. The upper part of the neck of that calyx is just in the way a little bit, but we'll start to fragment the stone into, as I say, 2 to 3 millimeter fragments, and then wash those out using the Venturi effect. And also we flush up from below through the ureteric catheter. So if we just talk a little bit about sizes, because that was something which was asked before. Stuart, for your PCNL was 26 French, was that right?
No, we used a 30 French.
You used a 30 French sheath. And Sharon, you were 17 or 16?
16.5.
16, okay. And so this sheath here is a 13 French outer diameter, so just a little bit smaller than Sharon's. And then the micro PCNL, I think, is 4.5 French. If anybody knows different, then please tell me, but that's with the all-seeing needle, 4.5 French, also using a laser to fragment the stone. But you can't wash the fragments out using the ultra mini PCNL, so it's basically a flexible, well, you know, the same concept as a flexible ureteroscopy. You'll fragment the stone fragments, and if you're not going to pick them out, which you can't do, then they're going to have to clear naturally.
So a couple of questions have come through which follow on from what you've just said. So what are the advantages and disadvantages of this over supine? And there's such a low transfusion rate anyway with a standard PCNL. Why use this mini kit?
So whether you do this prone or supine is...
standard, not supine.
Oh, okay, sorry. So what are the advantages of this over standard with a low transfusion rate? Well, the big the big increase advantage is that the access size is much smaller. So in fact, we've collected data on all the ultra mini perks done in the UK up until December of last year. There were 32 done. There were no transfusions, and patients, 28 out of the 32 went home the next day. Analgesic requirements are much less. There's no requirement for a nephrostomy tube post-operatively in the majority of those. We haven't collected the data, but on the 4 patients that we've done, their analgesic requirements post-operatively were much lower. And we know there is very good evidence that complications from PCNL are directly related to the size of the PERC tract. So although the transfusion rate's low, I would suggest that if you can downsize your tract, it's likely that your complications are going to be lower. So I think it has got significant advantages. In some particular stone cases it may be useful, such as stones in the calyceal diverticulum particularly. It may be useful in the population which Sharon showed as well, in the paediatric population where obviously you don't want to use the bigger kit. So I'm not suggesting for 1 minute that it would be the right operation for all stone cases, but I think it's certainly useful for the armamentarium, and there is very good data, as I say, that complications are directly related to tract size. So we're fragmenting the stone into smaller bits, and we'll start to wash them out shortly. Are there any other questions that anyone's got about the technique or the kit at all?
So there's a question about how long the whole procedure lasted.
Well, I like to look at it a bit like the robotic surgeons do with their robotic prostatectomies, where we just talk about the docking time. So the fragmentation time is 22 minutes. The whole procedure actually took slightly longer at 105 minutes.
Thank you.
But this patient went home the next day. We left a ureteric catheter in overnight, which you'll see at the end. So it's probably equal in length to what you would spend at a flexible ureteroscopy. You haven't got the concerns which you would have with a flexi of not being able to gain access in 1 in 10 cases. But don't forget, this was our first case, so I would suggest that as our experience with it improves, we had a theatre full of observers, we had Janak who was taking us through it. I think that our operation times will certainly come down.
So, question on microphone 3, Mr. Smith, I think.
Yeah, a real life question from in the room. You have to wait your turn with all of this electronic questioning. We've done a few of these too, and as you know, I'm very much a 2-wire person rather than a 1-wire, and having a wire outside gives me some reassurance. We use a dual lumen catheter for having a wire outside because the one in does get in the way. We're watching this quite relaxing, really, watching as live surgery that's already happened. But all of these fragments that are in the renal pelvis, are you concerned about washing those elsewhere in the kidney? Because sometimes it's a bit more difficult to look around with an Ultra Mini. What's your technique for those?
So just to come to the 2-wire issue first, I don't think that this precludes a 2-wire technique. You can still have a wire on the outside, and in fact for our second 2 we did use a second wire on the outside so that we still got that security of having access back into the kidney. I was a bit concerned about the fragments flushing around the kidney, but in fact you can look into other calyces with this Ultra Mini kit. The calyces which we accessed using it didn't have any stone fragments in once we'd flushed all the fragments out. And you can see now, just to interrupt, we're flushing the fragments out through this side port. We've got a little swab to collect the fragments on, and the fragments do wash out quite nicely. I was a little bit sceptical as to this Venturi effect and whether it would actually work. So if you believe that this idea of the stone fragments going from high pressure to low pressure is actually true, then if you use your ureteric catheter to flush up and get the fragments out, and you're also flushing through this side port, then I think if you've got fragments elsewhere in the kidney, they will be flushed out from this, as I say, low pressure area, from the high pressure area to the low pressure area. So yes, a bit concerned, but I don't think that's proved to be an issue in the cases that we've done. Will?
Ollie, you mentioned the advantages of reduced complication rate, no external drainage afterwards, reduced analgesia. Does this open the door to day case PCNL, do you think?
I think it does. I mean, there are certainly, certainly not in the first few cases. You'll see at the end, you can see now the collecting system, just 1 or 2 fragments still left. You'll see at the end when we take out the sheath, we don't leave a tube, and for me that was quite a big step. I've always left a tube. I've never done a tubeless perk, and so it's kind of small steps at a time. I'm quite conservative, but the 4 cases we've done have all been fine. They've all gone home the next day, so I think if you do them in the morning and they're fine in the afternoon, I don't see any problem. There's no reason that you couldn't send them home the same day.
There's a great question for Andrew, just before he's been patiently standing there while Oliver does lots of talking, and then we'll come to the 2 microphones. Do we need endourologists, or could radiologists do all of this?
That's a great question. I quite often tease Ollie in theatre to get him to give me the scope to manipulate a wire, and then he turns around and smiles when the wire goes the right way. And I think as all these debates go about crossing specialties, we're all educated people, so if people get the right training, anybody can cross these boundaries, because this is, as you say, an endo procedure. I'm an endovascular surgeon. I treat aneurysms. I did an aneurysm yesterday without a vascular surgeon. So, yes, you could cross these boundaries in the right setting, in the right place, but teamwork, I think, is...
I think, Oliver, you better watch out. Let's go to microphone 3 and then microphone 1.
Hi, Sam Latta, Colchester. Ollie, when you put the wire in outside the sheath, did you find when you were trying to create the Venturi effect with the side port that it leaked and it wasn't as effective?
That's not something that I noticed. I'm not saying that it didn't happen. I don't think it was less effective at flushing the fragments out. Is that something you've experienced?
Yes, I found when the technique, Janet removes the wire, and I found that initially quite disconcerting.
Yeah.
However, the Venturi effect seemed to, because you had a pressure seal, seemed to be more effective. And when I certainly flushed with the side port with a safety wire in, that made it, it leaked around the Ultra Mini kit.
Yeah, no, that's interesting. I haven't noticed it, but I shall look out for it next time. Thanks, Sam.
Microphone 1.
This is more of a comment. With the 16 to 17 French mini PCNL, addressing the comment about, you worry that maybe fragments will go elsewhere in the kidney, I've worked out how to remove the sheath, and then you can actually pass a flexible cystoscope through tissue and have a look around the kidney. And if need be, you can put the rigid scope back, or you can manipulate a fragment back into the renal pelvis.
Okay, thank you. I'd just like to use Andrew's knowledge a little bit more, if he has any comments in general about puncture and using ultrasound versus fluoroscopy. And then after he said that, there's another minute or two just for any more burning questions if you want to come up to a microphone. Don't send any more through on the app because there's a delay, so probably your question won't get to me before the end of the session. So if you've got any more questions, go up to the microphone, please.
I mean, as a radiologist, I primarily use ultrasound. I make a point of looking for the bowel. Always look at the bowel. I always show the urologist the bowel on the way in just to show them how close it is. You can see it, you can identify it, you can avoid it. Always look for pleura as well. So I always use ultrasound. Having said that, those trained with fluoroscopy, it works. You have to image in 2 planes to target the calyx after you've done your retrograde. So it's whatever you're used to using. There are some occasions when I've targeted the kidney with ultrasound and then we just use the retrograde to fluoroscopically guide the needle that last bit. But as a radiologist, I will use ultrasound because that's what I do. I can see the structures in between the skin and the kidney because I'm not just targeting the calyx, I'm avoiding these other structures.
Great. There's a question about whether you put anything like flow seal down these tracks if you're going to go tubeless.
No, one of my colleagues has suggested that. I've never tried it, but I think it would be a reasonable thing to try.
Does anyone in the audience do that? Do you want to put your hand up if you do that? No.
You'd be surprised how quickly a nephrostomy track seals once it's fallen out. The number of patients we get, or the tube's been out for 16 hours, we can't get back down them. So these holes close up.
And certainly your scar looked impressively small at the end of that video.
Yeah. So you saw the incision there and the stone fragments that we got out. Patient was stone-free afterwards, as I say, home the next day.
Further comments? No. I think one thing we haven't covered with any of the speakers is about antibiotics, and there's a session on antibiotics later today. So maybe just if each of the panel can just tell us what their sort of standard antibiotic prophylaxis is.
Yeah. So these patients, if they've got a history of infection stones, particularly for the larger stones, they'd get a week's worth of antibiotics preoperatively. According to cultures, they get appropriate antibiotics on induction. Our local policy is augmentin and gentamicin, and then they normally get 5 days oral antibiotics post-operatively.
Stuart?
We make sure our patients have sterile urine pre-operatively. A case like this, on the background of recurrent urinary tract infections, was on prophylaxis. Our trust policy is for 120 milligrams gentamicin infusion IV during the procedure. In this lady, we upped that to a treatment dose post-operatively when she was pyrexial.
Again, we make sure that the urine is sterile, but the prophylaxis is based on any sensitivities previously. If it's been sterile previously, they get gentamicin and teicoplanin, just a one-off at induction.
Okay. Great. Well, I'd like to draw the session to a close. We'll finish on time. And thank very much our speakers for putting such excellent videos together and handling questions fired during their talk. Particular thanks to Stuart, who had a slight glitch with his video, which is not what you want just before you're about to speak. Thank you very much for all the questions. It was a good interactive session. Thank you very much.